Guided tissue regeneration, or GTR, is a groundbreaking technique in periodontal therapy that focuses on regenerating lost periodontal structures. By using a barrier membrane, clinicians can selectively exclude certain cell types, such as epithelial and gingival connective tissue cells, from the defect area. This allows periodontal ligament cells to repopulate the site, promoting true regeneration rather than mere repair. In this video, we'll explore the principles, materials, procedures, and innovations that define GTR, as well as its clinical applications and limitations. Let's begin by understanding the core concept behind this regenerative approach. The principle of guided tissue regeneration is based on the selective repopulation of cells. When a barrier membrane is placed over a periodontal defect, it prevents the fast-growing epithelial and gingival connective tissue cells from migrating into the area. This exclusion creates a protected environment where slower-growing periodontal ligament cells can colonize the site. The result is the regeneration of the attachment apparatus, including new cementum, periodontal ligament, and alveolar bone. This approach is a significant advancement over traditional methods that often result in long junctional epithelium, rather than true regeneration. Barrier membranes are essential to the success of GTR. They are classified into 3 generations based on their material properties and bioactivity. The first generation consists of nonresorbable membranes, such as expanded polytetrafluoroethylene EPTFE, Gore-Tex, and dense PTFE. The second generation includes resorbable membranes made from collagen, polylactide, polyglycolide, and other materials. The third generation features resorbable bioactive membranes with added growth factors, representing the latest advancements in regenerative technology. Each type has unique advantages and limitations, which we'll explore in detail. First-generation barrier membranes are non-resorbable and require a second surgical procedure for removal. Common materials include expanded polytetrafluoroethylene EPTFE, Gore-Tex, dense PTFE, nucleopore, millipore filters, ethyl cellulose, and semi-permeable silicone barriers. These membranes are highly effective in maintaining space and excluding unwanted cell types, but their need for removal can increase patient discomfort and surgical risk. Despite these drawbacks, non-resorbable membranes remain a reliable option in certain clinical scenarios. Second-generation membranes are designed to be resorbed by the body, eliminating the need for a second surgery. These include collagen-based membranes like Biomed, Periogen, Paroguide, Tissue Guide, Biostite, Bioguide, and Biobar. Synthetic options include polylactide and polyglycolide membranes, such as Guidor, Vicryl, Atrisorb, Result, EpiGuide, and Biofix. Other materials like periosteum, connective tissue grafts, and alloderm are also used. The resorbable nature of these membranes improves patient comfort and acceptance, though they present unique handling challenges. The third generation of barrier membranes incorporates bioactive components, such as growth factors, to further enhance tissue regeneration. These membranes are resorbable and often made from advanced materials that interact positively with the body. For example, EPTFE is known for its inertness and biocompatibility, allowing tissues to accept it without adverse reactions. The addition of growth factors accelerates healing and promotes more predictable regenerative outcomes, representing a significant leap forward in periodontal therapy. Absorbable barrier membranes offer several advantages in guided tissue regeneration. They eliminate the need for a second surgical procedure to remove the membrane, which reduces surgical time and patient discomfort. Patient acceptance is generally higher, and there is a lower risk of losing regenerative tissue due to the absence of a second surgery. These benefits make absorbable membranes a preferred choice in many clinical situations, especially when patient compliance and comfort are priorities. Despite their benefits, absorbable membranes also have some disadvantages. Proper manipulation and adaptation of the membrane against the root surface can be technically challenging. These membranes are often more expensive than non-resorbable options, and clinicians have less control over the rate of biodegradation. In cases of infection, retrieving and removing the membrane can be difficult, as it may have already begun to disintegrate at varying rates. These factors must be considered when selecting the appropriate membrane for each patient. Guided tissue regeneration is indicated in specific periodontal defects where regeneration is possible. These include narrow 2- or 3-wall infrabony defects, circumferential defects, Class II furcation defects, and certain recession defects. The selection of cases is critical for achieving successful outcomes, as not all periodontal defects are suitable for GTR. Proper diagnosis and defect assessment are essential steps before proceeding with this regenerative approach. There are several contraindications to guided tissue regeneration. These include medical conditions that contraindicate surgery, active infection at the defect site, poor oral hygiene, smoking, excessive tooth mobility, shallow defects, insufficient width or thickness of attached gingiva, short root trunks, generalized horizontal bone loss, advanced lesions with little remaining support, and multiple defects. Careful patient selection is crucial to minimize complications and maximize the chances of regenerative success. The surgical procedure for guided tissue regeneration involves several key steps. First, a full thickness flap is raised using vertical incisions, extending at least 2 teeth anteriorly and 1 tooth distally to the treated tooth. Next, the osseous defect is thoroughly debrided, and the root surfaces are planed. The barrier membrane is then trimmed to fit the defect, extending 2 to 3 millimeters beyond the margins. The membrane is secured with a sling suture, and the flap is repositioned and sutured to cover the membrane completely. For non-resorbable membranes, removal is required after about 5 weeks. A critical aspect of GTR is the stabilization of the fibrin clot and protection of the wound. The barrier membrane preserves the root surface and prevents apical migration of the gingival epithelium. This allows for connective tissue attachment during the early stages of wound healing. By maintaining space and protecting the clot, the membrane creates an optimal environment for regeneration, supporting the formation of new periodontal tissues. The outcome of guided tissue regeneration is influenced by both barrier-independent and barrier-dependent factors. Patient-related factors include plaque control, smoking, and stress. Defect-related factors involve the type and morphology of the defect, tooth mobility, and gingival thickness. Surgical technique, such as flap management and closure, also plays a role. Barrier-dependent factors include the adaptation and stability of the membrane, sterility, and premature exposure to the oral environment. Understanding these variables is essential for optimizing regenerative outcomes. The PASS principle, introduced by Humley Wang and Boyapati, outlines 4 critical factors for successful regeneration: primary wound closure, angiogenesis, space maintenance, and stability. Achieving primary closure prevents bacterial contamination, while angiogenesis ensures a robust blood supply. Maintaining space allows for tissue ingrowth, and stability of the wound and membrane is vital for predictable healing. Adhering to these principles increases the likelihood of achieving optimal regenerative outcomes. Root biomodification is an adjunctive step in GTR, aimed at enhancing new attachment formation. Citric acid, with a pH of 1, is applied to the root surface for 2 to 3 minutes after thorough debridement. This process removes the smear layer, exposes collagen fibers, and may open dentinal tubules, facilitating cementogenesis and collagen adhesion. The treated root surface is then irrigated, and the flap is repositioned and sutured. This technique accelerates healing and may improve regenerative outcomes. Growth factors are polypeptide molecules released by cells in the inflamed area. playing a crucial role in wound healing. They are secreted by macrophages, endothelial cells, fibroblasts, and platelets. Key growth factors include platelet-derived growth factor, insulin-like growth factor, fibroblast growth factor, and transforming growth factor. These molecules regulate cell proliferation, migration, and differentiation, promoting the formation of new bone and connective tissue during periodontal regeneration. Enamel matrix proteins, such as amylogenin, are secreted during tooth development and play a role in a cellular cementum formation. The application of enamel matrix derivatives, like Emdogain, has been shown to promote periodontal regeneration by mimicking natural developmental processes. These proteins are delivered as a viscous gel to the defect site, encouraging the formation of new cementum and supporting the regeneration of periodontal tissues. Biologic modifiers are materials or proteins that can alter host tissue to stimulate or regulate wound healing. They may act locally or systemically and have the potential to promote regeneration of periodontal tissues. These modifiers influence cell migration, attachment, proliferation, differentiation, and matrix synthesis, making them valuable adjuncts in regenerative procedures. Their use is expanding as research uncovers new ways to enhance healing and tissue regeneration. Several biologic mediators are used in periodontal regeneration. Platelet derivatives, such as platelet-rich plasma and platelet-rich fibrin, provide a concentrated source of growth factors. Growth and differentiation factors, including platelet-derived growth factor, IGF-1, TGF-beta, FGF-2, and vascular endothelial growth factor, stimulate cell proliferation and bone formation. Differentiation factors like bone morphogenic proteins regulate bone induction, maintenance, and repair. Enamel matrix derivatives and extracellular matrix proteins also contribute to the regenerative process. Tissue engineering in periodontal regeneration employs protein-based, cell-based, and gene-based strategies. The goal is to reconstruct lost tissues by combining three essential elements: a scaffold to support cell growth, signaling molecules to direct cell behavior, and cells capable of regenerating the desired tissue. Advances in tissue engineering hold great promise for the future of periodontal therapy, offering more predictable and effective regenerative solutions. Guided tissue regeneration has revolutionized periodontal therapy by enabling the regeneration of lost tissues through selective cell repopulation and advanced biomaterials. The evolution from nonresorbable to bioactive membranes, the integration of growth factors, and the application of tissue engineering principles have all contributed to improved clinical outcomes. As research continues, new materials and techniques will further enhance the predictability and success of regenerative procedures, offering hope for patients with advanced periodontal disease.